Now, I hope this goes all right. So, as we said, we can think of the urinalysis as being the poor man's renal biopsy. And even if you don't go down, I mean, sometimes from the consult service, we go down and look at the slides ourselves because there are things that we need to see on the actual slides. But even if you don't do that, you can still learn a tremendous amount from just the urinalysis. Okay, so starting out, then I'll just mention that some characteristics of urine collection that will help you if you are able to have control over them. You know, it'd be great if we could always look at urines first thing in the morning on our patients because they're the most concentrated at that time and they'll contain the most good stuff. Of course, we don't usually have that choice. But we do have the choice of asking whoever collects the urine to make sure that it's a clean catch and that it's a midstream because it'll wash out the things that are in the urethra that'll otherwise confuse things, as you particularly know, like many times in women, you'll just get all these squamous cells, and then you can't make any judgment at all about what the white cells and the bacteria mean and even the culture. Okay, so now let's start out here by talking about the different things that just the appearance of the urine can tell you. Sometimes this is you know, what the lab is describing the urine as being, and sometimes it's what you are seeing the urine as being either in the collection cup or when you're looking at inpatient in the Foley bag, whatever, you know. Okay, so let's look at these. What kind of appearances? Okay, we've got the appearance of cloudy and foamy. We'll talk about several different ones. Red, coat-colored, smoky gray, and green. Okay, so let's think about each of these in turn. Okay, so what kind of things does cloudy mean to you, usually, when you see a cloudy urine? Yeah, so usually the first thing you think of is infection, but there's a couple of other things that might come to mind. Anybody know what else you can think of when you see cloudy? Proteinuria is one. What would you say? Right, that's right. Yeah, you could have white cells in the urine that are not because of infection, exactly. And then there's a couple of other appearances as well, and one is going to be the appearance of phosphates. So if the person has recently, like if they've had a meal that's containing a lot of phosphates, you know, meat or whatever, oftentimes there can be a tremendous amount of phosphates in the urine, and the urine will look just incredibly cloudy, and especially if it's been in the refrigerator, which of course most of the time it isn't when we see it, but and that can be very confusing. But of course when the lab examines it, there will be no white cells in it, it'll all be these sort of powdery crystals. And oftentimes when you look at the urine in the cup, if it's got a lot of phosphates in it, they will settle out and look sort of like chalk dust at the bottom as opposed to being a cloudy, purulent looking urine. If there's lymph for any reason in the urine, it can also look a little cloudy. Okay, so what does the foamy appearance mean? What does that tell you is in there? And what kind of protein specifically? Albumin, yeah. So it's because of, you know, the turbulence of urinating will sort of whip up the albumin in the urine. It's the same thing as like whipping up an egg white, you know, and you get this foamy head on the urine. Some patients actually can tell you, if you see a patient that has newly diagnosed proteinuria or nephrotic syndrome, you can actually get an idea from them how long it's been going on by asking them if they've noticed that the urine is foamy. There's an amazing number of people that don't notice at all, but there are some patients that are very attuned to this. So like I have this patient that I follow that has minimal change disease, adult minimal change disease, and when she needs to go on steroids, it just goes right away, and then it stays away, and then when she gets a relapse, you know, I don't need to see her at any sort of interval because most of the time if I would see her, she'd be fine. So I just sort of like don't see her, and she'll might chart me every so often and say, okay, I've got the foamy urine again, could you put in, you know, lab orders, and I'll come in, and then she comes in and, you know, gets the urine, and then we figure out what to do depending on how much protein is in there. So patients can be very observant about that, and that can be very helpful. Okay, what about the appearance of red urine? What does that mean? And this can mean a whole bunch of things. So what are some of them? Actually, let's see. We have a whole slide on red urine, but what are some of the things that you think of? So you think of blood, obviously. What else do you think of? Myoglobin. Okay, what else? Right, that's good. Okay. Have you ever seen that? Do you know what color it is? Yeah, more orange, correct. That's right. Yeah, have you ever seen that? Anything else you can think of? Pizza. That's excellent, excellent. And you need to know that to work in a hospital like this, you know, because you're on the west side, you've got all these Eastern European groups. And most of the time, I'll tell you that when you see the beets in the urine, the red urine from beets, It'll alarm the doctor. It doesn't alarm the patient at all because the patients all know this. They know that when they eat beets, their urine is going to turn red. So they do not become frightened or run to the doctor or anything. But the doctor becomes frightened if they see it. Okay, so yeah, so that's some of it, blood, et cetera. So we'll look at that a little more later. Okay, now what about dark or coke-colored urine? So in other words, it's that sort of brownish urine. Do you know what I mean? Okay, bilirubin, yeah. And you'd think that it would be yellow because everything else is yellow, in the patient. But no, it is coke-colored. Okay, and what about the smoky gray? What does that mean? As opposed to coke-colored, it's more a gray color. Any idea what that is? What? Yeah, that's right. And so it'll be red cells in the urine, is what you can see. I mean, well, and specifically glomerulonephritis. And it's one of the characteristics that you would see like with post-infectious, post-strep can do that. I'm not sure why. I had always thought in my mind that maybe it was something similar to the way blood turns to look like coffee grounds in the stomach, maybe because of the action of acid or something like that, but that's the way it is. It doesn't come out looking like blood if it's a glomerulonephritis. Okay, and then the final one, green, what does that mean? What does green mean in any other body fluid, like in sputum or pus or anything like that? What? Well, that might be part of it. What else? What kind of infection is it? Pseudomonas, that's right, yeah. And so it'll be stuff like Pseudomonas. And then there's these medications. Some of them are like, I can't remember, Doan's little liver pills or, some of the over-the-counter type medications. And then also amitriptyline can do this. Okay, let's see. Let me just give you a few more ideas here on the red urine. Okay, so number one, of course, beets. And then urates. A lot of times it's not too obvious in patients. Sometimes it is apparently a cause of alarm in mothers that have babies where they can see that the urine looks sort of brownish red on the diaper, but urates can do that. Not a pathological amount, just having them there. And then pyridium. How many people have ever ordered pyridium for a patient with severe dysuria from a urinary tract infection? It works great, but you do have to notify the patient or let the patient know that their urine is going to turn bright orange, not red, but bright orange when they take it. And usually the emergency department is really good about letting them know that, but sometimes that can slip by. And then dilantin, rifampin, and then X-lax. You remember all our little chemistry experiments where we'd have to use those indicators for, acid and base, and X-lax would turn urine pink because of the acid, Okay, and then, so those are the things that are like non-pathologic. And then the pathologic ones, blood, and don't forget about hemoglobin. So if it's free hemoglobin, if you've got some sort of hemolysis going on, then you can see the red urine, and then myoglobin, of course, and then porphyrins. Okay, any questions about those? All right. Now let's see. Next thing, let's look at specific gravity. So now specific gravity, you got to know about this because this is what comes out on the dipstick. You can get osmolality if you want, but it's a bigger deal. You have to order it separate. Here you get it just by clicking urinalysis or urinalysis with reflex culture or whatever. So just remember that what it is a ratio of the weights of equal volumes of urine over pure water. And so it's always going to be like 1.0 something, 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 And when you say these, teach your students or anybody that's presenting to you to pronounce those as 1025, 1030, that's how you say them. So you don't have to say 1.009. You can say 1009 or whatever, like that, okay? But the maximum, anyway, in people, in humans, is going to be 1030 if you are severely volume depleted, and if you are maximally concentrating your urine with normal kidneys, you should get up to about a 1030 or 1025. Okay, so the thing is, sometimes you can see urine-specific gravities, I'm sure you all have, that go above 1030, and that is not possible just with regular urinary concentration. So when you see that, you have to be thinking of something that's going to affect that first thing, ratio of equal volumes of urine and pure water. And this is based on weight, so just think of things that could be really heavy that would be in the urine that would make it be more than 1030 despite being maximally concentrated, or sometimes not even maximally concentrated. Okay, so remember that it correlates roughly with osmolality, but osmolality measures the number of particles and not the weight, the way specific gravity does, okay? Except if the urine contains a heavy substance such as, and the most common one that you're going to see, of course, is going to be glucose, Mannitol weighs the same as glucose, 180, so if there's any reason for the patient to have received mannitol, IV contrast dye with iodine is really heavy, so that'll bring you way up there. And then ethylene glycol, antifreeze, that can also bring it up. So all those things may give you a really high specific gravity that is like beyond human physiologically possible. So remember that. And then the other thing that gets complicated about that is if you're looking at somebody like with severely uncontrolled diabetes and you're looking at the specific gravity, you can't draw any conclusions about how volume depleted they are by just looking at the specific gravity, because maybe all you're looking at is glucose in the urine and you're not really looking at a dehydrated patient who is, like reabsorbing water like crazy. Okay, now this is the way it correlates roughly with osmolality. And you can see, pick any point, like pick the point around, 200 or 400 osmolality, and just look at the specific gravity that goes with it. And in general, what we say is that, well, the normal serum osmolality is going to be what? Serum. Yeah, it's going to be around 290, 300, something like that. And then isotonic for urine specific gravity. If you're talking about isotonic to plasma, what's that going to be about? If you're talking about a person who cannot concentrate or dilute their urine, such as a person with chronic kidney disease, what sort of specific gravity are they going to run all the time about? Anybody know? If they're not doing anything. It's basically right around 10, 10, 10, 12. And you can see that right off there. Look where 300 would fall in the osmolality, and then look up, and you can see it corresponds to about 10, 10. And you can see all the way along there's a pretty good correlation between osmolality and specific gravity, with the maximum osmolality, 1200, correlating pretty well with the maximum specific gravity of 1030. You see what I'm talking about there? Okay, but if you throw in something like a heavy substance like glucose, you can see how at any given osmolality, the specific gravity is going to be quite a bit higher because it's based on weight rather than particles. Okay, got that? Okay. And by the way, if at the end of this, I don't know, I think these slides are being, or the lecture is being posted on SharePoint, but if anyone wants these, I always offer these to the renal fellows. If anyone wants a copy of the actual slides, because sometimes people use them for teaching. So if you think you want a copy of the actual slides to use, just email me and I'll send you one, okay, that you can use. Okay, let's see. Let's go on here quickly to proteinuria. All right. Now, the things to remember are, we talked about the foamy appearance. Now, also remember that the dipstick measures only albumin and not paraproteins. So if you have multiple myeloma or something like that in your differential, don't just get a urinalysis with the dipstick protein. You have to actually order a protein creatinine ratio, okay? You can also get a false positive on protein if you have a really high urine pH. And for the quantitative estimate, use the spot protein creatinine ratio, of which the normal should be less than 200 or 150, okay? All right, now the next thing to look at here is, and what I'll do after we finish talking about the dipstick, I got, let's see, I think 2 more slides on the dipsticks. And then I'm going to show you a bunch of things that can be seen in the sediment, and then we'll talk about those. And then the last 5 things, I'm just going to show you 5 sort of tests of sort of urine and renal function that you can find that are not, sediment tests, but things like the FINA and stuff like that. And we'll come back and talk about protein creatinine ratio at that time. Okay, all right, now urine pH then. Remember that most people, most of the time, who have meat in their diet are going to have a urine pH that is less than 7. It's going to be on the acid side. Just because when you eat meat protein, it gets metabolized to these acidic amino acids and you have to get rid of them. And so in general, we teach that most people have to get rid of about 1 milliequivalent per kilogram of body weight per day of hydrogen ions. So if you weigh 70 kilos, you have to dispose of 70 milliequivalents of hydrogen ion a day to keep yourself in acid-base balance. So most of the time, if you look at the urine pH, it's going to be on the acid side, okay? However, you will see people that aren't like this, okay? But first of all, in people who are acidotic then, you should always see a urine pH of 5 if the kidney is doing what it's supposed to. So if a person is acidotic, their kidneys should be putting out acid and helping to compensate for the acidosis. If they're not doing that, that means that something's wrong and or that the kidney is the actual cause of the acidosis, like with renal tubular acidosis, all right? Now, what happens when you see a value of greater than 7? You don't see that very often, but there are certain things that you need to think of, and they are going to be things like renal tubular acidosis, where you can't reabsorb bicarb either proximally or distally, and so you got bicarb in the urine, the pH is going to be way high. So this is when you'll see pHs that are above 7. If you're taking a carbonic anhydrase inhibitor, who takes those? What kind of people will you see with those? We see them, internists see them. Why do we see them? Yeah, glaucoma, or people that have recently had eye surgery, because it works in the eye kind of like it does in the kidney, inhibits carbonic anhydrase and prevents intraocular increases in pressure. And so if somebody's on, a carbonic anhydrase inhibitor, like acetazolamide, they may develop a increased urine pH. And it can also, I should say, waste sodium, which can be a problem. And then the other people that you'll see this on is people that have a vegetarian diet, because those people, instead of ingesting, foods that generate acidic amino acids, will be ingesting foods that contain things like citrate and bicarbonate, which are all either are bicarbonate or they're metabolized to bicarbonate. So those people will always run on the alkaline side of 7 instead of the acid side. So a person like that with a vegetarian diet. And then the one that we're all taught to think of course, which is UTIs with urease-producing bacteria, specifically Proteus, Pseudomonas, and Staph, not as far as I know ever E. coli, though. Okay, so just remember those. All right, and then 2 more things on the dipstick that we will see sometimes. First of all, leukesterase, which indicates the presence specifically of polys, not lymphs, but polys, and suggests infection or at least inflammation. And then nitrites. And these are interesting because they're made from dietary nitrates by the action of reductase-producing bacteria. And so you can have a UTI with negative nitrites if under certain circumstances. One, if you don't have very many dietary nitrates, so you have nothing for the bacteria to turn into nitrites. Second, if your bacteria are not the reductase-producing type. And third, which often happens with UTI, the person is like urinating so frequently that the urine doesn't have time to sit in the bladder and have that reaction occur. Then you can have a nitrite-negative UTI. All right? All right, now here's the part where I'm just going to show you a bunch of first cells and then casts and a couple of crystals and things that you see in urine, and see if you can identify these. Okay? All right. Any questions about these things having to do with the dipstick or the chemical analysis of urine first? Okay, what are these? Or what are most of them, I should say. Right, okay, red cells. And how can you tell? What tells you that they're red cells? You see the thing in the middle that's got the granules in it? That would be a poly for reference. And so you can see that the red cells are smaller, and you can see that they do not have any sort of granules. They're considered, refractile, which means they're just sort of shiny, and you don't see nuclei and stuff in them. Sometimes you see them sideways, that biconcave disc, or part, at a 45-degree angle, so you can see them at angles like that. And then the ones you see that appear to have little bumps on them are actually what you call crenated. Do you know what that means? When you see, what does that mean? What does crenated mean, and why do they get crenated? Well, I think you're thinking of something a little different, which we'll see shortly. I think you're thinking of dysmorphic, right? Crenated actually just means wrinkled, or I don't know if it literally means wrinkled, but that's what it means, So in other words, if you have a very concentrated urine, very high urine osmolality, it'll pull water out of the cells, just like it pulls it out of any kind of cells, and then the cells will get wrinkled. You can see a couple over there on the left that look like they have little bumps on them, and those are just the wrinkled cells, the crenated red cells, okay? Now, okay, so they're refractile biconcave, and sometimes they are dysmorphic. So this is what is dysmorphic. So you can see a couple of pretty normal looking donut ones, and then you see the ones with the little ears sticking off them. And why are they like that? Why do they get like that? Because what are they trying to do? That's right, they're trying to squeeze through the injured glomerular basement membrane. They get all beaten up like that, or little pieces come off, or they have little, ears sticking off them. So when you see those, so when you order dysmorphic RBCs, that's what you're getting, a count of these, how many % of these are dysmorphic, which most of the time, even when nephrologists order them, the answer is like 0 or 1 or something like that. But when you see them, that's very helpful, because it tells you that it's not blood, coming from a bleeding prostate or a stone or a tumor or something like that. It's coming through the glomerular basement membrane. It tells you that you've got basement membrane damage, and just sort of corroborates the other thoughts that you should be having, that the patient has glomerulonephritis. Okay, that's just another thing you look for. Okay, got that? Any questions? Okay, next. Now, what are these? These are stained. I hope you can see them. There's a couple. You can see nuclei and cytoplasm stain in these. Any idea what they are? Take a look at the shape of them. That's right, polys. So you can see the polymorphonuclear nuclei, the lobes on them, okay? And this is one that was stained. It was actually stained with stain that was sitting in the lab for acid-fast bacilli, the counter stain, and you can use that also to look for polys, and they just showed up like this. So when you see a lot of polys, what does that tell you? You can see, in the background, there's some cells that are like smaller that are not taking up the stain. At least some of those are probably red cells, which do not take up stain when you try to stain them, okay? But when you see a lot of polys, then, you'll think about the kind of things we talked about with cloudy urine. You'll think about infection, inflammation, stuff like that, okay? Polys is always going to be infection or inflammation, but sometimes you'll see lymphocytes and things like that as well, which will not have the polymorphonuclear nucleus, but will have a mononuclear nucleus, which you can detect. And sometimes you can actually see in a regular stain EOs, or things that make you very suspicious of EOs, even without an EO stain, because the EOs are usually bilobed, and then you can do a specific stain for EOs that'll show you the red granules. Okay, so infection and inflammation. All right, now here is a type that you don't see quite as often. Let's see, I'll show you 2 examples. Okay, so the first one up there on the left is just a regular stained one with regular stain, and then the one on the bottom right is stained with something special. So can you tell, you see the cells that I'm talking about, so you can sort of pick out, you can see polys in there because you can see the nuclei, right? And you get the idea of how big the polys are. You see the cells that are bigger, they have the little tails coming off, and in the yellow slide you can see that one of them clearly has a tail and also has a single nucleus. I mean, there's no mistaking that thing for a poly or anything like that. You can see that one nucleus. So what are these? What? They're too big for that. Because look at the size of the white cells and the red cells. Any other ideas? What? These are cells, just single cells. Yeah, single cells. These are, think about, back to, yeah, tubular cells, that's right. So think about your first year in medical school, and you were looking through the microscope, and you looked at all those cross sections, histology, and you'd see the round things with the lumen inside, and then you'd see the basolateral side, about cells pointing toward the inside, and so that's the reason they look like that. They have those little pointy things where the apical side would be. And so these are just renal tubular cells that have fallen right out of the tubules, either proximal or distal. And when you see them, this is not normal. This is not anything that you would ever see in a normal urine. So when you see these are bad. And when you see them in large number, they're even worse. So what do they mean? What do you think they mean? ATN. That's right, yeah. So tubular, either acute tubular necrosis, or sometimes they'll mean things like interstitial nephritis, where you're primarily affecting the tubules. Tubular necrosis just means they die because they either don't have enough blood supply, so that's hemodynamic or ischemic, or because you've poisoned them with something like contrast dye or, aminoglycosides or something like that, and they just get dead and then they just fall out. The interstitial type would be they're inflamed and have all kinds of cytokines and things making them die, and then they fall out. But what they do is they fall right into the lumen, and then they go out in the urine, and you see them looking like that. Okay, so when you see them, that's a bad sign. Why are the ones on that side yellow? Any idea? I mean, this is another example of, we talked about how when there's bilirubin in the urine, it makes it look sort of coke-colored, and everything else in the patient looks yellow. Well, that includes their tubular cells. And so that when you see these, this is just a picture that we just took. We used to have a microscope with a camera on it here that we could run down, like if we were looking at a urine, we could just run down with the slide and take pictures of it. So this is pictures that we took. It's unstained. I mean, this is just exactly the way it looked to us, looking through the slide. So you see that. Because bilirubin, and the reason I show it is because bilirubin is a great stain. You don't have to worry about, staining too much, too little. You get all the architecture. Everything's perfect. So if you're lucky enough to see one, that's what you get. Okay. So again, that means acute tubular injury that is happening like right before your eyes. So either it's happening all at once, like you have an ischemic event and all the tubular cells die at once, or it happens over a relatively short period of time, like maybe you have a septic episode where the person's sick for a little while, or where they're getting a nephrotoxic substance such as aminoglycoside for a while, and they're having some death of cells. Okay, so that's that. Okay, now, all right. What about these? So look at the ones, the large ones. Yeah. Okay, and so this looks like just like a pap smear, if you remember, again, back to medical school, So the cells are really big. These are the biggest ones you'll see. Probably down there in the lower right are going to be things like a white cell and a red cell, it looks like to me. And you can see the nucleus of the squamous cell is very small compared to the cell body, and the cell itself looks very flat because you can see the edges folded over. It doesn't look like a round cell. It looks like a really flat cell that's folded over. So when you see those, you're looking at some sort of contamination from the urethra, the vagina, and if you see a lot of those reported, then you know that your specimen is, again, not any good as far as telling you whether there's an infection, a UTI or not, a cystitis, okay? That's the importance of them. Okay, all right, so that's them. All right, now look in the upper right-hand corner at those darker cells. Let's take a look at those. So look at what size they are compared to white cells and what size they are compared to squamous cells. Okay, so what are these? Transitional, yeah. And how do you know? Because they're sort of the in-between size cells. They're bigger than any of the things like over in the far right, you can see the one cell with the tail, which is probably a renal tubular cell, and then down below, that's probably a white cell. Like I showed you in the previous slide, the squamous cells are bigger, and then these cells, they call them the fried egg cells. That's what they call them, because that's about the ratio of the yolk to the cell, and they'll tend to cluster. Sometimes they'll be nucleate. And they'll often be in clusters like this. You see them, they really aren't of any diagnostic significance. Sometimes you'll see them in people with Foley's, probably because the Foley balloon, just rubs against the wall of the bladder and some of the transitional cells come off. But if you see people that have recently had chemotherapy or certain types of chemotherapy, they can have lots of transitional cells because those cells that rapidly turn over will oftentimes get injured by chemotherapy, and so you'll see them. And I suppose if you had somebody with transitional cell carcinoma, you might see them as well. But they're not really of any other diagnostic significance that I know of. And they do tend to form in clusters like that. Okay. All right, now let's see. I'm now going to show you 4 types of casts. Let's see if you can identify these. So these are the things that form when stuff is in the renal tubules and it sticks together and then it comes out in the urine. So typically a cast is going to be, if you see cells in it, it's usually going to be anywhere between 2 and 4 cells wide, and the sides are going to be straight, just like the inside of a tube, and the diameter is going to be pretty uniform. So those are the kind of things you look for with casts. Okay, now this is the most common type of cast that you will see or hear about, and you can see that it is almost invisible. The ones, particularly the ones on the right, are just about invisible, and the ones on the left are pretty transparent as well and take up stain poorly. And the name for these is hyaline casts, because hyaline means glass-like, but what's the significance of them? And oftentimes, I don't know about you guys, but oftentimes when I order a urinalysis, you'll get these reports where the lab will say like 20 or 30 hyaline cells or hyaline casts per low-power field. The regular cells, they'll always report per high-power field because they're always looking under the 40 objective, but the casts, they always report them under low power because that's how they look for them, under low power. Otherwise, if you went under high power, you'd spend all day, looking for these things in ways you can see them well under low power. But what does it mean when you see hyaline casts? Anybody know? Is it bad? Is it not bad? And if it's not bad, why not? Or if it is bad, why is it bad? Any idea? they're very nonspecific, and they're very, normal, essentially, or they can be normal. And the time when you'll see them is when the urine is very concentrated for any reason, like first thing in the morning, or patient jumped out of bed, came to clinic without eating anything, and then they're sitting there mildly volume depleted, in your clinic. And so there'll be the proteins that are made actually within the renal tubules. There's these things called Tam-Horsfall proteins that are made in the distal convoluted tubules. So they're not sneaking through the glomerulus. They're not pathologic. They're not out of the blood being filtered into the urine. They're actually made in the tubular cells, and they just sit there. And then when the urine's really concentrated, they just stick together and they form these hyaline casts. So it usually just means that the patient is able to concentrate their urine, which might be a good thing, Okay, so don't be alarmed, even if you see huge numbers like 20 to 30 reported. Okay, now what are these? So these are not transparent. What are these called? Any idea? And these are also pretty nonspecific and frequently reported. Look at the texture of them. See, when you look at a cast, just look at the chance and see what's outside the cast, what's inside the cast. If it's a cell if you think you're seeing cells inside the cast, you should see the same cells outside the cast, the same type of cells outside the cast. And then you see examples that are stuck together, which are, the cast formation. So here, you don't really see much outside the cast. And when you look inside, you don't see anything recognizable, right? You can't identify cells. Because remember, I told you, typical cast is going to be anywhere between 2 and 4 cells wide. So that's not going to be a bunch of cells so small that you can't see them. That's not how big casts are. So these are just what are called granular casts. And again, they are completely, as far as I can tell, nonspecific. You can see them with AKI, with CKD. You can see them with exercise. I remember once when I was I think I was a fellow, and we were doing, at the place where I was doing my fellowship, they were doing this laboratory on medical students, and they had the medical students all spin down their urine and look at it. And so the medical students were working in these little groups, and they found, to their amazement, there was many of the groups contained at least one medical student whose urine was loaded with granular casts, which was completely inexplicable because you don't usually see that many in normal people. And so the instructor just took all the people who had the granular casts and identified them and said, is there anything that you have in common? And what they had in common was they had all been out playing basketball at the noon hour. And so they figured it had something to do with either the exercise itself or being a little volume depleted with the exercise. So that was a real learning point for me. Okay, that's what granular casts are. So they're not too helpful. Okay, now this type is, again, this is one that we took right through the microscope. Looked just like this, no stain. What type is it? Look at the cells inside. And if this was a real slide, you'd be able to focus up and down, and you would see that all around there would be the same thing. Any idea what they are? Red cell casts, that's right. So what do they mean? What sort of diagnoses would you entertain if you saw a lot of these? Yeah, glomerulonephritis of any type. So you could see this with post-infectious. Worldwide, probably the most common cause would be IgA nephropathy. In this particular case, it was Wegener's. So anything like that can do that. And you can see how they actually do stain red. We didn't do a thing to this slide. That's just the color that it looked. And if you had looked around the outside and focused up and down, you could see red cells every place. Okay? So that means glomerulonephritis. Rarely it can mean interstitial nephritis as well, but usually what it means is that the glomerular basement membrane is so damaged that red cells and protein both are sneaking through, and then the protein sticks together the red cells and makes these casts, okay? As opposed to things like a tumor where you would have blood, but you wouldn't have the protein to stick it together in the cast form. And then the last type of cast that I want to show you is this one. Okay. Now again, remember our little golden-colored person with Billy Rubin. It's the same person, but what do you now see in the cast? And see how clearly you can see this? You can actually look at those cells, and you can see, you wouldn't confuse this with a red cell cast, right? Like the one we just looked at. So you can see what's in it. What do you think they are? Look at the size and the shape. Yeah, it's a tubular cell cast, because you can see, especially over there on the top right, you can see one cell that's actually very oblong. It's got that little tail on it. If you look at them, you can see some cells that have the nuclear nucleus. And again, if you were looking actually under a scope and able to focus up and down, you would appreciate the architecture even more. So it's the same thing as seeing free tubular cells. It just tells you that tubular injury is occurring in this person who had hepatorenal syndrome or something like that. And again, you could see, if you look around, you would probably be able to see tubular cells in the outside as well. Okay? All right, now let's talk about, I'm just going to show you two types of crystals here. One real common. All right, what are these? Oxalate. And what do we call these also? If you're trying to teach somebody them and have little phrases that will remind them what oxalate looks like, what do you say? That's not monthly. Well, what I read is envelope, although to me, I always think of these as pyramids because I think they actually are. I think they actually do have the shape of pyramids, you know, where they're pointy. But anyway, so so is this bad or good or neither or what? What does it mean if you see oxalate crystals? What? I mean, yeah, you can see them in anybody. I mean, it doesn't mean a thing if you see them generally. Um, Oftentimes it means that people have eaten something that contained oxalate, you know, which would be like what? Like what sort of things might the person who appears with these? It'll be, you know, I think the number one thing is like rhubarb. So if they've had any rhubarb pie recently, if they've had iced tea, nuts, you know, things like that. Chocolate, I think, has oxalate in it. So, but what's the one situation where looking at the oxalate crystals can help diagnosis? Anybody know? Yeah, ethylene glycol, exactly, because it gets metabolized to oxalic acid. And so sometimes if you have a person, it's not that you would necessarily treat them, well, I guess you might actually treat them differently, but you have the person that comes in very sick, unstable blood pressure, severe metabolic acidosis, high anion gap, and you're considering that whole differential of high anion gap. And if you see these, and you're not going to see just a couple of these the way you might in a normal person or the rhubarb eating person, you would see sheets of them. And if you saw that, you might be able to actually move ahead with your treatment, or at least with your focused questioning, or having somebody go out to the house and look for the bottle of antifreeze or whatever to get going on the treatment of a person with ethylene glycol poisoning before you got your ethylene glycol level back. Okay. All right. So, all right. Now, what about these? And what's the name for these? I mean, what's the name of the type of crystal? And then what's the nickname for them? Well, it's coffin lid. You got the idea. Okay. He said tombstone, but it's coffin lid. Okay. And what kind are they? These have several actual names too. You'll hear them called struvite, and then they can also be called triple phosphate because phosphate is the anion, and then you have calcium, magnesium, ammonium for the cation, so that's the triple part, and then phosphate. And so what kind of people get triple phosphate crystals or struvite crystals? And you will see these described. What? Right, or people with chronic infections. Right, that's right. And why is it people with Proteus? Yeah, that high urine pH. That's what you need. So people, and sometimes, I just saw a patient recently with this. You don't see these very often, but I did see a patient who had actually staghorn calculi made of these things because it was a person who had chronic infection. And the deal with chronic infection, you know, if you have chronic infection, sometimes you get these really unusual causes like Proteus, you know, that you wouldn't see in your ordinary UTIs. And so what they do is they, you know, split urea with urease to make ammonia, make a very high urine pH, and they also form a lattice work of crystals, or a crystal that has all these holes in it, so they can sit in these little crystals and stones, and they're protected from antibiotic, and then they can also keep putting out their ammonia and making a nice little alkaline shell around the stone, which then allows it to grow even faster. And so sometimes you can see very fast growth, which results in staghorn calculi. And then the other thing you can see, sometimes if you see people that have had long untreated struvite stones, is the stones will actually be layered like a sedimentary rock, which I think is because they're laid down at different times. So since you've got the three different cations, you know, if they have more or less calcium in them, they're going to be more or less radio opaque, and so you can actually see stripes in the stones. But again, this is people with chronic infections and urea splitting bacteria. Okay? All right. And then how about this one, which is not a cast, but what is this? Can you tell what it is? And if you can, what's the clue? It's a thing over there on the right, upper right. Anybody know? Trichomonas. Why do you say that? How can you tell? What's the clue? Yeah, right. If you look carefully, you can see the little flagella coming out there. out of its little nose on the right-hand side, okay? And when you look at if you actually look at a slide, if you've ever done that, to look at an actual slide, you'll see things that look, I mean, it just looks like a sea of white cells usually, and then you'll see one that's like this, so that's how you tell. But otherwise, the size is the same, the shape is almost the same, but it's just that madly waving flagella that will clue you that it's trichomonas. Okay, all right, now, let's see, so then 1, 2, 3, 4, 5 types of tests of renal tubular function that I want to finish up with here. Let's see how we're doing here. Yep, we've got time. Okay. Okay, so I just want to mention a couple things here. We'll talk about these 5 things. All right. Now, looking at the formulas for estimation of creatinine clearance or GFR. Okay. The Cockcroft-Gault is the one that we use for creatinine clearance, and it's based on age, gender, weight, and serum creatinine, just those 4 things. So it's actually, you can actually like calculate it with a calculator. MDRD eGFR is based on age, gender, race, serum creatinine, albumin, and BUN, but it contains things like natural logs, so you can't actually calculate that in your head or with a pocket calculator too easily. Okay. Now, at Metro, you can get both of these, I hope you know this, by using the dot phrase .crcl. And if you put that in your note, up will come the patient's latest creatinine clearance based on whatever their latest creatinine is, as well as their latest eGFR based on the data that they have. And then you don't have to leave the dot phrase in there, you can take them out, but at least you know what the creatinine clearance is and what the eGFR is, okay? And outside Metro, so sometimes, like you'll get labs from an outside lab that you're seeing the patient and you don't have that eGFR, so you have to calculate it. So if you need to do that, then you can use a calculator, and what you can Google is estimated GFR. So do not Google eGFR because you'll get all these things about epidermal growth factor receptors, what I discovered. So you have to put the word estimated in there. But then you'll get a nice little calculator and you just put in your blocks and then you can get it. Okay, so now why do we use one versus the other? Okay, so here's the difference between them. The one on the left is going to be the Cockcroft-Gault, and the one on the right is the MDRD GFR. And then the thing at the bottom is going to be the actual GFR as determined by giving them a radionuclide tracer and just getting the actual GFR of the person. So you can see that when you look at the Cockcroft-Gault creatinine clearance, it's actually a little high. It tends to estimate a little bit high. And that's because, especially as you develop chronic kidney disease, your tubules will actually secrete creatinine a little bit more than usual, or a larger proportion than usual. Because we always teach that creatinine clearance, is a true GFR because creatinine is, filtered and it's not metabolized, blah, 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 and so on, just like an inulin clearance. But in actual fact, it gets inaccurate as you get down to the end stages of renal failure, so it's going to be on the high side. The eGFR is quite accurate, and it saves you all that stuff like collecting 24-hour urines and stuff like that, so it's really convenient. And so why do we have both? Why do we need them? Any idea why you need the creatinine clearance at all? I mean, because you could argue that all we need is the eGFR, because the eGFR tells us the stages of chronic kidney disease, and you can tell exactly what stage your patient is in and what their prognosis is by just doing the eGFR, But why do you need the creatinine clearance? Anybody know? Why do we have to have it? The only instance that I know of where you need it is where you're using something like Micromedics or Lexicomp, and you come up against this. You're going to order a med, the dose adjustments, and you get a message like this. They're all based on creatinine clearance, and I think that's because all this work was done before they had eGFR, and they're not going to turn around and redo everything based on the eGFR, so we're stuck with using creatinine clearance. But if you use eGFR and base your antibiotic doses or whatever you're adjusting on the eGFR, a lot of times you're going to just way underdose what the person needs. So you need to use a creatinine clearance in that instance, and that's when you turn to your .crcl. Okay, second, spot urine protein creatinine. Okay, based on the assumption that the actual amounts in milligrams of creatinine and of protein that you excrete over a period of time is going to be constant all day long. And the thing that's going to vary is the concentration, because it just depends on how dilute or concentrated your urine is. So you just take that factor right out by using a ratio between, then it doesn't matter how dilute or how concentrated anything is. Okay, You can get it without a timed urine sample, so it's great. You don't have to have your patients taking home jugs and all that stuff. And it's pretty constant and reproducible, and you can use serial ratios for following the same patient. So this is an example of how good it is, looking at the line of unity, the actual, protein, 24-hour protein excretion, and using the protein creatinine ratio against that. So the normal is like 150 or less, and then nephrotic range would correspond usually to 3,000 or more, And this is an example of how you would use it. This is a patient I had that had lupus. She was going along pretty well there, and then she started developing more proteinuria, and we thought, well, let's give her some Cytoxan and see if it does anything. So you can follow the result of giving her your therapeutic intervention by looking at the protein creatinine ratio. So that would be one way that you'd use it. Okay, then the third one, I just want to mention the FINA here, and I think you know that when the FINA is when you have volume depletion, the FINA is going to be very low. We always say less than 1%, and as you probably know here, many times it's incalculable because the lab will only report that the urine sodium, which you need to do this, is less than 10, so then you can't actually calculate it. It's like 0, so you know it's really low, okay? But then the other point is that if you have tubular injury, like with ATN, it's going to be high, like greater than 2%. You'd think that there'd be more variation, but there's really not. The range is just very small there, and then in between is kind of your gray zone. But the point I want to make here, in case you don't know, is you can get it off of Epic. There's something, depending on exactly which screen you have and how you've arranged your things, you'll have a thing called clinical calculators. And when you look at that, you should look at it if you haven't, because it's got all kinds of good stuff like the AA gradient and stuff that you need. And you can find, under the commonly used, you can find the FINA. And when you plug in the values, it'll calculate the FINA for you. And then you don't have to worry about making decimal errors or arithmetic errors and stuff like that. Okay. Then the next thing is the anion gap. You're probably quite familiar with this, but in serum, normally you have the same number of cations and of anions. And in the cation category, it's almost always going to be sodium, and then there's a little bit of potassium, calcium, magnesium, zinc, all that stuff. And then on the negative side, you're going to have mostly chloride, some bicarbonate, and then a bunch of things that are called unmeasured anions, which are usually phosphate and sulfate, which are regular metabolic products, and albumin, or proteins, especially albumin, okay? And so they balance out. Now, if you have, and then the amount by which the unmeasured anions exceed unmeasured cations is called the anion gap, and you calculate it just by taking the sodium minus the sum of chloride plus bicarbonate. You should get about 10 plus or minus 2. That's the normal situation, okay? Then if you have a person who has a so-called normal anion gap acidosis, like this, where they are simply losing bicarbonate, either through the GI tract or sometimes through the urine, then what happens is when they reabsorb stuff from the renal tubule, from the glomerular filtrate, they'll just simply reabsorb more chloride because there's plenty of chloride around. So if you don't have a lot of bicarbonate, you reabsorb more chloride. And then in your blood, you'll show up with a higher chloride to balance the lower bicarbonate. And when you go to calculate the anion gap, it's going to be the same. Okay? And so this is people that just lose bicarbonate, like with diarrhea, renal tubular acidosis, where that's the only problem. And that's opposed to the people who have a high anion gap. And these people, what they're doing is they're creating, or for some reason have, ingesting or creating an acid that is not normally present. So in other words, they'll have something, anion, H+, and then some sort of anion that's not supposed to be there or not in high quantity, like keto or lactate or something like that. So when you see that, think about, and then what happens is the hydrogen ion consumes bicarbonate, gives you the low bicarbonate, and the unmeasured anions, ketos or lactates or whatever, get added to the unmeasured anion category. And then when you go to do your calculation, you get this high anion gap. So you should be thinking about things like lactic acid, keto acids, uremic, which is just a whole collection of different stuff that adds up to like 20, and then the various toxins like ethylene glycol, methanol, and salicylates, okay? So that's how you use that. And then the final thing that I want to talk about is the urine anion gap, which is calculated a little bit differently than the serum. It's just sodium plus potassium minus chloride. That's all you have to have. And this is the way it works. It should be negative in the presence of a metabolic acidosis, okay? And why is that? It's because when you look at the main anions and cations in the urine, they're going to be sodium potassium, and ammonium, with ammonium being a marker for acid excretion, okay? And those will balance chloride and bicarbonate, and usually the bicarbonate is just about zero, whether the urine is normal or abnormal, it's usually zero. And so thinking about the yellow things, sodium plus potassium minus chloride, just look at these three examples then. We'll look at a normal person, a person who has a metabolic acidosis but is otherwise normal, and a person who has a renal tubular acidosis. Okay, so calculate the urine anion gap for the normal person. What's that going to be? Sodium plus potassium minus chloride. What's it going to be? -5. That's right. Okay, that's fine. All right. Now, calculate the person with the normal kidneys and the metabolic acidosis. What's their urine anion gap? 50, which is what it should be, because it shows that the kidneys are doing their best to combat the acidosis by making a lot of ammonium. See how much ammonium there is in there. Now, the person with RTA who can't do that, what's their anion gap going to be? -5, okay? So that tells you, when you see this, that that there's something wrong with the kidney, and that it's probably going to be an RTA, distal RTA or type 4 RTA, or one of those, that they just cannot do the normal acidification processes. Or with chronic kidney disease, you could see this happen as well. Okay? I think that's it. Let's see. That's the end. Okay. And so again, if anyone feels like to have a copy of the slides to use for teaching, where you can actually take it apart and use certain parts, just email me and I'll be happy to email those back. And